All right, so the purpose of this round is really, we thought a couple of years ago that none of our fellows should ever graduate their training program without feeling the sort of the sweat of being behind the podium. So we started this tradition in the spring of having each of our graduating fellows give a Grand Rounds topic of their choice. So today is the first of that series for the spring. So without further ado, I'd like to get Omar to come up. You may not recognize Omar now. Today he and Wahaj look more like defendants than the residents we've seen. They've always been in scrubs for the last 3 years that I've seen them. But they clean up well. So Omar is in his third year of cardiology. He's really a product of Texas education. You went to, that's right, UT Southwestern for med school and internal medicine, and then here for cardiology. And he's staying here for interventional cardiology, so you'll see him around again next year, and we're pleased that he's staying with us. So without further ado, Omar is going to talk to us about this topic. So tell us what you know.
Thank you. So it's my pleasure today to speak to you all. The title of my talk is Cardiac Surgery in the Left Atrial Appendage, Two Birds Meet One Stone. It's a little joke for Dr. Aman's lecture right there. I have no disclosures. And the basic clinical question that I want to try to answer today or shed light on is, in a patient that's undergoing a cardiac surgery, does it make sense to also remove the left atrial appendage at the same time or exclude it? Is there benefit or harm associated with this practice? If the appendage is gone, does that protect us from future embolic events? So this question often comes up because we have patients with pre-existing atrial fibrillation that enter the OR, and then we have patients that leave the OR that develop new onset atrial fibrillation. So I think this is something that we can shed just a little bit of light on. And to do that, we'll talk about atrial fibrillation, we'll talk about the left atrial appendage itself, the surgical methods of closure, as well as more of our contemporary devices. And then we'll talk about what recent studies there have been, as well as some outcomes historically. And we'll talk about what future directions we can look forward to. So here's some infographics on atrial fibrillation. We know that it's the most common cardiac arrhythmia affecting millions of individuals worldwide. It is estimated to cost approximately $26 billion per year in the US. These patients are 5 times more likely to have stroke, as well as 2 times more likely to be admitted to the hospital and 3 times more likely to have multiple admissions in the hospital. So it's a very pervasive condition. And we know that as we get older, it becomes more common. It's estimated that age 60 and above, 1 in 25 Americans will have atrial fibrillation, and at age 80 and above, that number will increase to 1 in 10. And what about atrial fibrillation that occurs after leaving the cardiac surgery suite? We know that it's actually quite common. It occurs in up to 40% of patients. Here are some numbers from the most recently published low-risk TAVR trials. Approximately a third of patients in the SAVR arm at 30 days had new onset AFib. We also know that it occurs soon after the procedure, and it has a substantial impact on hospital resources, costing thousands of extra dollars, as well as increasing hospital stays. And we know that several factors play an important role in the development of new onset AFib after cardiac surgery. There's perioperative ischemia causing some atrial oxidative stress. There's autonomic imbalance, increased sympathetic tone, and as well as postoperative inflammation, which can lead to conduction changes in the myocardium, among others. And what happens to these patients? So here's a meta-analysis of 40,000 or so patients, and they looked at the development of new onset AFib post-cardiac surgery. And what they found was overall, for short-term mortality within 30 days, the odds ratio was 2.29, so much worse outcome there. They found that patients with new onset atrial fibrillation tended to be older, have lower ejection fraction, have heart failure, have longer cardiopulmonary bypass times, among other risk factors. And they found that this long-term effect on mortality seemed to persist in those few studies that had longer follow-up at 1 to 4 years. This isn't to imply a causative relationship, but rather speculative. One can imagine that patients that develop new onset atrial fibrillation have a worse substrate than those that do not. Not a lot of us like war. We know it's not a good thing. Some people would even argue that the left atrial appendage is the same way. I've even heard it referred to as the dumpster of the heart. But let's talk about what it's actually good for, what functions it has. So it has important roles in neurohormonal regulation. It's a rich source of ANP, or atrial natriuretic peptide, important in sodium as well as fluid balance in the body. The longer we have atrial fibrillation, the more fibrosis we have. The more fibrosis we have, the less ANP that's secreted. So you can imagine that if you were to completely remove the appendage, then that rich source of ANP would be gone, and you can have potential fluid and sodium issues in the body. It has been postulated as a source of atrial arrhythmias itself in a minority of patients. And we know in the normal function of sinus rhythm, the atrial appendage has this pulsatile flow in it. However, in atrial fibrillation, we lose that pulsatility, then we have stagnation of blood within the appendage. And when we have stagnation of blood within the appendage, that's where we run into problems with thromboembolism. And we know it's sort of has this cardiac reservoir function. Essentially, when the left atrium is exposed to high volume, high pressure, the appendage acts as a sort of reservoir for that. It's been postulated that if you were to remove the appendage, you would lose that reservoir function. The atrium would be more susceptible to increased volume, increased pressure. That could lead to some atrial stretch. That could lead to some fibrosis, and that could lead to atrial fibrillation. And it has so many different morphologies. So the relationship of the appendage to the rest of the extracardiac as well as cardiac structures can vary. It's been described most commonly in 4 different morphologies, the chicken wing being the most common, followed by the cactus, the windsock, and the cauliflower. The cauliflower morphology has been implicated in more thromboembolism. The appendage also tends to have an orifice, a neck, and a body, and usually has between 1 to 4 lobes. More lobes tend to be worse. And this is really the crux of the issue. What we're worried about for the appendage is that it's a nidus for thrombus. And this is an often quoted paper out of authors from the Mayo Clinic or Mayo System in 1996. And they evaluated studies that described a left atrial thrombus. They found that in 23 studies, when the patient had non-valvular AFib, 91% of the time, the thrombus originated from within the appendage itself. That led to an editorial comment that there's a convincing argument that in patients with AFib, removal of the appendage should reduce the risk of stroke. So we know with atrial fibrillation, the higher the CHA2DS2-VASc score, the higher risk our patient is for a stroke. We also know that the higher the AFib burden, that's bad as well. But I want to impress upon you, thromboembolism is not the only mechanism of stroke in our atrial fibrillation patients. There have been some interesting temporal associations associated with atrial fibrillation and stroke. These are patients that had continuous monitoring devices. And we actually see, oddly enough, that a good proportion of patients had no AFib episodes or atrial high rate episodes within the 30 days prior to their stroke. Atrial fibrillation has also been associated with a hypercoagulable state. So what I'm trying to say is that the link between atrial fibrillation and stroke could also be an epiphenomenon. Atrial fibrillation may represent a marker for an overall increased risk of stroke, and patients with atrial fibrillation and high AFib burden tend to have more risk factors for vascular non-cardioembolic stroke as well. And that's something that I don't want to sink the whole theory behind the left atrial appendage, but I also want to temper expectations here. So how do we manage the appendage classically, surgically? This is me as a cardiologist talking about this, but I'll try my best. Essentially, you have excision, which is complete removal of the appendage, and then you have exclusion, which is separation of the appendage from the rest of the atrium. In panel A, we see an example of an epicardial exclusion, meaning the appendage is sewn from an epicardial standpoint and excluded from the rest of the atrium. Panel B, we see an endocardial approach to that, where it's excluded from the rest of the atrium. In panel C, we see the use of a stapler device in assisting for excision or complete removal of the appendage. Stapler device can also be used to exclude the appendage as well. In panel D, we see the cut and oversew technique in which the lateral border of the heart is brought up. The appendage is cut with scissors or electrocautery, leaving a less than 1 centimeter cuff, and then that is sewn together to achieve hemostasis. And there have been a lot of different surgical methods that have been described, variations of these. So this is a study that's often quoted when it comes to the efficacy of surgical appendage closure out of the Cleveland Clinic. And what they looked at was in their sample of patients that underwent surgical appendage closure and had a subsequent TEE. So again, we have a selection bias for patients undergoing TEE after appendage closure, but still interesting things. 137 patients, they defined an unsuccessful closure as a patent left atrial appendage, a remnant stump that was too large, or an excluded appendage, however, still had persistent flow in it via color Doppler. They found in their experience, majority of patients underwent exclusion of the appendage with a suture or stapler, meaning the appendage is still there, it's excluded, and the rest of the patients underwent total excision or removal of the appendage. Only 40% of their closures were successful by their criteria. And we see that when the patient had a suture or a stapler that was unsuccessful, 41% of those had a thrombus in the left atrial appendage. When the patient had an excision or total removal of the appendage, none of those had a thrombus. The excision was termed unsuccessful because in all of those cases, the stump left was too large. So what we can see is that perhaps it's not the worst thing in the world to leave a stump that's too large, but leaving a persistent or patent left atrial appendage would perhaps be the worst thing here. And what happens to these patients clinically? So here's another study where they looked at patients who had post-op CTA of the appendage, and they had surgical suture ligation. They found that complete appendage closure was achieved in 64% of the patients. Again, suboptimal, better than that 40%. But these incomplete appendage closures are the ones we really have to watch out for. That's a quarter of patients. And what happens here? In A, we see that these incomplete surgical appendage closures, approximately 25% of them had a stroke. And then when they're not receiving anticoagulation, in panel B, we see that more than 50% of them had stroke at follow-up. And in their analysis, an odds ratio of an incomplete closure was 16-fold greater risk of an embolic event. So very bad things happen. So where are we with appendage closure in general? We know that for atrial fibrillation, the mainstay of therapy is oral anticoagulation. That's been shown in multiple trials. Atrial fibrillation, warfarin, NOACs, DOACs, these have all been offered to our patients. But what we know is that it's estimated roughly 50% of patients that should be on an oral anticoagulant are not. 1 in 6 patients that should be on an anticoagulant are deemed too high risk by their physician. And we also have patients that are on oral anticoagulants and they develop a bleeding episode, and thereafter we don't want to continue them on these medications. So handling of the left atrial appendage or discussion of the left atrial appendage has emerged as a tool that we can offer to our patients. And how has this been achieved in the contemporary era? We have the Boston Scientific Watchman device, which has been, of the percutaneous options, the most widely studied in the PROTECT AF, PREVAIL, and Continued Access registries. It's been shown to be non-inferior to warfarin for endpoint of stroke, CV death, or systemic embolization. It has been associated with a reduction of major bleeding, including hemorrhagic stroke, a little bit higher ischemic stroke, and that can be a whole nother topic. And it generally requires 45 days of oral anticoagulation after implantation. The Lariat suture delivery device utilizes a transeptal puncture and endocardial approach along with a pericardial approach to place a loop around the ostium of the appendage and closes it. It's important to note that it's not FDA approved for appendage closure, but rather for soft tissue closure. It has had good technical success, and usually there's no limited course of anticoagulation needed afterwards. The Amulet device is a second-generation Amplatzer device. It has had good technical success. And usually it's given with antiplatelet therapy, aspirin and Plavix, after implantation. It's usually been published in retrospective, non-randomized case series, totaling 1,000 patients or so, but generally has lacked control groups. We have the AtriClip device. So the AtriClip device is a parallel titanium crossbar clip with woven polyester fabric. It's approved by the FDA for closure of the appendage with direct visualization. It can be utilized with an open heart approach. It can be utilized with a thoracoscopic approach as well. And the key or the goal with this device is to provide uniform pressure and closure at the base of the appendage so that we prevent any development of a persistent leak within the appendage. And under direct visualization, you can put this device in and hope to avoid injury to the close by circumflex artery. And it's been also shown to have good technical success on follow-up CT, TEE as well. So now that we've talked about some methods of closure, let's roll back and talk about what studies, what clinical outcomes have been associated with appendage closure with cardiac surgery. So there are several meta-analyses on this subject, and in general, for the meta-analyses, whenever you have cardiac surgery and appendage closure, it tends to support it as a promising strategy with a reduced odds ratio of a subsequent stroke or embolic event, especially in patients with pre-existing atrial fibrillation prior to entering the operating theater. However, given that these meta-analyses, we have to consider all of the studies that consist of it, and the majority of patients tend to be from observational data. There's a paucity of randomized controlled trials. Large weights of data tend to come from single centers or even single surgeons at times. Endpoints are evaluated in a retrospective manner. There's no strict definition of stroke. Various methods of closure are used across these studies. So in one experience, suture exclusion can be used, and another stapler, another cutting of the appendage. So usually there's also little to no data based on what the success of those closure methods have been. And we don't know if these patients are discharged on anticoagulation or not. So looking at the meta-analyses, they give us a good idea, but we still need more definitive evidence. Furthermore, there's usually a heterogeneous population of patients undergoing these procedures, whether or not they have prior AFib, whether they're going for a rheumatic mitral valve surgery or a CABG or any other open heart procedure. So this is an interesting study, the LAX trial. It was presented as an abstract at ESC 2017, Barcelona. And they took 187 patients referred for CABG or valve surgery, regardless of a prior AFib diagnosis. And they randomized them to ligation and double suture of the appendage versus none. And they took a brain MRI prior to surgery, after surgery, and 6 months after surgery. And their primary endpoint was stroke, TIA, or silent cerebral infarction. Here in graph A, we see in red is a closed appendage group versus blue, not closed. And we see at follow-up, there was less of their endpoint. When we look at harder clinical endpoints and we take out the brain MRI criteria, again, we see a difference. However, it does not approach statistical significance, likely underpowered in this case. This is another interesting study out of the Mayo Clinic, where they took 10,000 of their patients over a 5-year period undergoing CABG and valve surgery. They used propensity score matching to develop 461 matching pairs to assess the outcomes of surgical appendage closure versus none during cardiac surgery. And they found that in patients that had surgical appendage closure, they had more than double post-op AFib, which we know is a bad thing. And they found in these patients that there was no significant influence on risk of stroke or subsequent mortality. So based off of this study, this group concluded that there was no incremental benefit to surgical appendage closure and that it's perhaps associated with this risk of new postoperative atrial fibrillation. One thing to keep in mind is that in this study, most patients did not have preoperative atrial fibrillation. An interesting study out of Duke. in which they queried the STS database, which is very robust, greater than 1,000 institutions, 90% of CT programs in the US. They wanted to assess surgical appendage closure versus none in patients with atrial fibrillation at baseline who underwent cardiac surgery. They included patients above 65 years of age, and they found that approximately 37% of them underwent surgical appendage closure during cardiac surgery. And here are their outcomes that they were looking for. And their results, in the first panel here, we see a readmission for thromboembolism. Separates out at 1 year, continues at 3 years. They saw less in the surgical appendage closure group in orange versus blue without. All-cause mortality, they also found less, and a composite endpoint, they found less. They also looked at discharge anticoagulation status, whether or not they were discharged on anticoagulants, and they found that patients that were discharged on anticoagulants or discharged off of anticoagulants, I should say, seemed to do better when it came to this endpoint of thromboembolism. Again, this is just something that piques the interest. It's purely observational in nature, but again, should lead up to something that gives us a more definitive answer in the form of a randomized controlled trial. And then here's another trial out of the Mayo Clinic, several of the same authors, where they took 70,000 patients with private insurance, expanded the age to include all adult patients. And they found in this database, approximately 6% of patients had surgical appendage closure. They used propensity matching to get them into matching pairs, and they stratified them based on prior AFib or no. And they found that patients tended to do better with surgical appendage closure if they had this diagnosis of atrial fibrillation prior to entering the operating room. What future directions do we have to look forward to? So we have the LAOS-3 study headed out of Canada, and what they're going to include are patients with a history of atrial fibrillation or atrial flutter and a high CHADS VASC score undergoing a clinically indicated surgical procedure. They're going to randomize them to left atrial appendage occlusion versus no left atrial appendage occlusion. A suture or stapler device will be used for occlusion or a regulatory approved closure device. And their primary outcome is going to be ischemic stroke, TIA with positive neuroimaging, or systemic arterial embolism. And they're going to follow them up for 4 years. When this study is published, it's going to be very interesting to note what the method of surgical closure is that will be used is, and what the success of that surgical closure will be in interpretation of the results. But I think it'll shed us some good light on this killing two birds with one stone question. The ATLAS trial is sponsored by AtriCure, and it's going to study the AtriClip device. It's going to include patients without documented history of atrial fibrillation, also enriched for higher risk, and it'll randomize them 2-to-1, 2 with AtriClip and 1 without. And it's going to look at the primary outcome will be perioperative complications, but really it's the secondary outcome that we'll be most interested in, especially these thromboembolic events. And they're going to also assess for this complication of development of postoperative atrial fibrillation. So hopefully this study will also shed us some light into this question. So what can we conclude? We know that atrial fibrillation is a very common condition. It affects several of our patients that we refer for cardiac surgery. It also affects several of our patients that leave the operating room suite. We know that the left atrial appendage has been implicated as a very large blame for a lot of things. Is it our most lethal attachment, or is it simply a victim of bad reputation? How you surgically manage the appendage matters immensely. Various methods of closure have various methods of success. And now, in the contemporary era, we have new devices that could provide some high technical success for closure. Surgical manipulation of the appendage is not totally benign. We see this increased risk for postoperative atrial fibrillation that's been hinted at some of these studies. And in general, there are some promising trends with appendage closure that have been published, but again, we have no definitive evidence to help guide us. Essentially, we're going to need randomized clinical trials to help guide us further. And ultimately, what's the role of anticoagulation with all of this? Anticoagulation has several benefits. If we can replace that benefit with handling of the appendage during a cardiac surgery and not have to worry about anticoagulation, will we be able to have the benefit of no appendage, and will we be able to lose the risk associated with anticoagulation? So this will ultimately be the real question for our patients. And that's it. Thank you very much.
Thanks, Omar. That was, stay here for a second. That was surprisingly masterful.
It's surprising.
No, very nice. I mean, no, I mean, this is your first rounds here. You did a very, very good job. I mean, that was a complicated topic, and you took us through it and asked all the right questions, I think. So now we'll have just a couple of minutes for some questions. We have microphones, if we can get one to Dr. Wolf. Yeah.
That was very well done. Thank you.
Thank you.
This area has been a passion of mine for about 20 years now. And a couple things I can fill you in on that you wouldn't know normally. The one study that suggested that surgical closure with staplers don't work very well was from Cleveland Clinic. Mark Gillenoff was one of the authors. But what he didn't disclose was he was also one of the inventors of the clip that they were getting ready to release. So he might have had a reason to say that other methods of closure weren't very good. Just something to keep in mind. I did use the first clip when it became available for minimally invasive procedures, and it seems to work very well. In addition to looking at the clip, we always use transesophageal echo at the same time. So we see an external view, because we're surgeons, I have a scope in, but we're also looking at TEE at the same time. I think that's important. And that's what we do here when we close the appendage. I've closed over 2,000 of them. I'm not sure it makes any difference which way it's closed from the surgeon, but of course it has to be done right. That's where the problem is. Sometimes it's not performed properly. For future directions, before I came over here 4 months ago, I had started an IRB study at University of Texas. We had permission to enroll 250 patients who were undergoing open heart surgery who did not have a history of AFib. And my goal was to see if we put a clip on and they got POAF, post-op AFib, and we didn't anticoagulate them, would they get out of the hospital quicker, which would save the system money? And secondly, what was the 30-day readmission? And in the study, it included follow-up with either Preventus or Zio patch for 2 weeks, monitoring at certain intervals over 3 years, which I think is important also. The method of follow-up to check for AFib is very important, but we thought a 2-week monitor would be sufficient. We preferred to use the link, but you can't have patients pay for a link if they don't have a history of AFib, but you can get the Preventus. We did not want to exclude people who had a low CHAD score, because really their biggest risk for AFib was not their CHAD score, it was the fact they were having surgery. So that's something that I'd be very interested to see if anybody here is interested in starting that trial up again. It may help answer some of the questions here. Then the question comes to how would you like to randomize it? The beauty of the study is this. If the patient's in the study and they agree to this, they've also agreed to not have anticoagulation post-operatively, which protects everybody. They're in the trial. They're not being anticoagulated. So I think it's a really great presentation. It's a very important topic. And I think there's a lot that can be done even here in the next couple of years to try to answer some of the questions that you've posed. Thank you.
Thank you so much for those insightful comments.
Thank you, Omar. Omar, please stay abreast of the topic, and we'll have you back in 2 years to give us the follow-up to these trials. All right, it's my pleasure now to have Wahaj Aman come up and join us. Also a third-year fellow with us. Wahaj did his internal medicine in Cleveland Clinic and is off to UT to do his interventional fellowship in just a couple of months. So Wahaj, tell us.
All right. Well, thank you, everyone. It's an honor for me to present at Grand Rounds. So yesterday, I received a phone call, rather frantic phone call. What is SOME? Is this a new cardiac biomarker? Is this like a new genetic chromosome that we don't know? It's social media, and we're going to talk about that. So I have no relevant disclosures. Here are my learning objectives. First, we're going to go through the basic terminologies and impact of social media, how cardiologists should use Twitter. We're going to talk a little bit about what the hashtag means and some pitfalls and precautions of social media. And if you want to start, what's the best way? And our conclusion. So what is social media? It is defined as websites and applications that enable users to share content or to participate in social networking. It is on the rise. It is expected that as of 2021, there will be more than 3 billion people using social media in some way, shape, or form. Across nations, from the year January 2017 to January 2018, places like India and Saudi Arabia showed a 30% increase in social media, and we saw a worldwide increase of 13%. It is expected that 7 out of 10 Americans actually use social media. And no age is immune to this, so 90% of the demographic between 18 to 29 is on social media, but people who are 65 or older, about 30% as of 2014 have joined social media as well. They're catching up. And so it is seeped in almost every aspect of our lives, and medicine is no different. A recent PubMed search on social media and medicine showed more than 4,600 papers since September 2018. There are expected to be 400,000 cardiologists on social media with a nice even split between Facebook and Twitter. We're going to be talking more about Twitter today. So in her seminal paper, Dr. Parvani and her colleagues gave us this roadmap on how a cardiologist should navigate through social media, whether it's through education, organizations, networking, journals, conferences, and advocacy, and we're going to touch on each of these a little briefly. So in order to prepare for my grand rounds, I thought, what would be it would be a good poll to ask how cardiologists use Twitter. And there was an overwhelming majority of people who said education, that's why we use it. And over 160 people voted. However, I got a lot of you need an all of the above option. So delving deeper into education, I got another poll and saying how is the best way for cardiologists to consume education, whether it's directly through journals, interpretation by experts, tutorials, which we're going to talk about a little bit, and then case-based educations. So we see here with over 140 votes, there was a nice even split. So we'll talk a little bit about journals on Twitter. As of now, all the major journals, including NEJM, JACC, Circulation, Nature, Lancet, are all on Twitter. Social media enables them to drive their social engagement using polls, images, questions, definitely help with their journal visibility. Social media helps them rapidly disseminate content to a global audience and actually hold Twitter-based journal clubs where physicians from all over the world can meet virtually and discuss the latest trials and studies. And it's now where they are using, journals are appointing social media editors. These are academic physicians who are experts in their field, but also have a base of online engagement so they can generate that. And as an example, this is from JACC. Dr. Narang, Dr. Freeman, and Dr. Parvani are all social media editors for JACC. So how do journals do this? Basically, they can, like NEJM does here, give a nice brief summary of the latest TAVR trials, whether it's Partner 3 or the low-risk Evolute trial, with a nice graph or an image to help us understand. Whether it's through the JACC journals giving us the latest in the primary prevention guidelines, whether it's the limit of physical activity, aspirin usage, the role of calcium score in the latest cholesterol guidelines. It can be through JAMA Cardiology giving us a nice case of RVOT, VT in middle-aged women and how best to manage that. Or surg intervention giving us a poll in the role of clippical loading and the timing, does that affect clinical outcomes? And in fact, answering that with the Champion Phoenix trial telling us that in fact it does not change clinical outcomes. So now this concept of alternative metrics or alt metrics is coming up. And in this paper by Dr. Pravani, they say that the impact factor of a journal might not actually translate into readership. And so the rise of alt metrics, which basically is an amalgam of social media shares, web traffic, and media mentions of a paper, can actually predict how well a paper does in terms of its impact factor. So as an example, this is from the JACC website. This is the study of cardiovascular events associated with SGLT2 inhibitors. And if we look on the left-hand side, there's this, here it's metrics. I don't know if anybody can see that. Anyway, yeah, on the left-hand side, there's a metrics. And if you click on that, it takes you to altmetrics.com, and it can tell you how many times this paper was tweeted, how many Facebook shares, and how many times it was picked up by news outlets. And if we wanted to see more details, we can actually see individual tweets about the SGLT2 inhibitor paper and every paper now. In her leadership page, Dr. Mary Walsh noted that now there's a term coming up called tweetations or citations on Twitter, and they can influence the impact factor of a publishing journal. And now, in fact, researchers are calling for a twimpact factor, which may be a timely metric to measure uptake and dissemination of research findings. Moving on to interpretation of literature by experts. So as a response to my poll, Dr. Ankur Kalra, as many of you know, was a structural fellow here, told me to follow experts in the field like Dr. Kirtane, Dr. Pinto, Dr. Greg Stone, and Dr. Putt, and sort of follow what they say about the latest trials, but also on controversial topics. So as an example, I'll go with Dr. Venkmurthy from University of Michigan, who takes on this huge Apple Heart study, and in a huge series of tweets, he talked about their false positives, false negatives, sensitivity, specificity. It's like 50 tweets, but which I've condensed here. But essentially, it's a must-read for anybody who is interested in that. And he concludes that it was a trial that had excellent specificity, but not the best sensitivity and positive predictive value. If you have to follow one person on Twitter, I would suggest it be Dr. Greg Stone, who was our speaker last week. I call what when he talks about different topics as bite-sized treats. And so this is him talking about MITRA-FR and why it didn't show the results of COAPT. This is him telling us his inclusion criteria for COAPT and how clinicians and institutions, if they apply this, can achieve the similar results. This is him talking about 3 randomized controlled trials on the PFO closure and how the number needed to treat is 20. And this is his take on the changing world of aortic stenosis and, in fact, how a new era has begun post-PARTNER 3 and low-risk Evolut trials. So, in fact, the winner of my Twitter poll was something called Tweetorials, which is obviously a play on the word tutorial, but it basically encompasses a wide variety of topics and is a form of #FOAMED, or free open access to medical education. And so whether it's Dr. Choi from George Washington giving us a tutorial on calcium score, Dr. Micheletto from Brazil on OCT, our former cardiac imaging fellow, Dr. Mate, on evaluation of cardiac masses, Dr. Mohun is actually a third-year fellow and has fantastic video tutorials on lower extremity physiologic studies, and Dr. Pravani herself giving a talk about a tutorial about social media and cardiology, many, many more. And then there are case discussions, so anywhere between choosing statins for the elderly to complex PCI procedures and what PCI strategy they should use up front, whether it's atherectomy or balloon and stent, et cetera, are all discussed in terms of polls, and then various opinions are given by experts after that. One of the best things about Twitter is how it engages fellows or fellows in training or FITs, whether it's through the hashtag fellows first and attendings posting questions or challenging cases and asking them to answer first, encouraging their involvement by using the hashtag FitTweetup. And in fact, in July of 2018, the ACC Fit Council organized a bunch of tweetorials with the hashtag Fit Survival Guide for first-year fellows, on a variety of fundamental clinical topics. So here's fellows first, attendings don't answer. Here's this EKG, which is calling this an MI, but it's an artifact. And this is a fantastic survival guide on antiarrhythmic drugs by Dr. Asneroff. Societies and conferences are now all utilizing social media. As an example, we'll take ASE. So this is them telling us about their booth at ACC promoting their educational courses. This is the latest guidelines by Dr. Zogby. And if at any point we want to know where Dr. Little is, we just log on to the ASE Twitter poll and find out what he's doing. It is now the new way of attending conferences. Whether you go there physically or you follow with the tweets, ACC has actually made it really amazing where you have a wide variety of topics and each one of them is assigned a tweeter, for example, an acute and stable ischemic heart disease all the way down to vascular medicine. And in fact, now this time they had early career tweeters, pathway tweeters, and FIT tweeters. And over the course of 3 days, there were more than 41,000 tweets that were generated with more than 8,000 participants, an average of 467 tweets an hour. And so that was pretty incredible. And one of our top influencers was, of course, Dr. Faza here. This Twitter led us to this fantastic slide, which is a summary of all the trials that were presented at ACC, courtesy of Dr. Rifat. And in fact, one of the highlights of ACC was this debate between Dr. Martha Gulati and Dr. Kern about the pros and cons of Twitter. And so here was Dr. Gulati with her carrots and as such, and Dr. Kern giving us a stern sort of a rebuttal. Ultimately, it was all in vain because Dr. Gulati won with a landslide. Although a lot of people pointed out that asking people on Twitter whether Twitter is better is a little biased. So we've spoken a little bit about hashtag, and what is hashtag? It's basically a metadata tag. It identifies and categorizes messages into a specific topic, basically helps you navigate easier. And in fact, there's a whole reference guide by the ACC, which has over 100 different terms for cardiology and ACC-related terms. So some of these you've already heard, like ACC Fit, others like in education, hashtag ACC SAP, and then grassroots advocacy and quality, like ACC Grassroots. All across the spectrum, every branch of cardiology has their own hashtag. One is for general cardiology, it's mostly hashtag cardio Twitter or hashtag cardio ed with 110,000 tweets between them. For subspecialty, it's hashtag, for intervention, it's hashtag radial first. For imaging, there's hashtag echo first, hashtag yes CCT, hashtag YCMR. But in our part of the woods, we have another saying when it comes to CT, and that's hashtag CT is king. We want to register this, but Twitter wants Dr. Mamarian to first sign up before we officially do this. A specific and a special mention must be made of the hashtag radial first. As many of you know, Dr. Sunil Rao from Duke coined this term in January of 2017. And in his own words, he did this to bridge the gap between evidence and the practice around the radial approach. And about 6 months after he launched this, there were more than 30 million impressions made on Twitter with using the hashtag radial first. Now, in January 2019, more than 121 million impressions with 60,000 new tweets using the hashtag radial first. I actually met Dr. Rao in CRF a couple of weeks ago and asked him whether this translates into practice. And we sort of both said maybe there's no way of knowing, but I thought, why not? Let's do another poll. And so I did another poll saying, does the hashtag radial first influence you in doing more radial cases? And with over 340 votes, 30% of them said yes. And that to me is more than 100 interventional cardiologists being influenced by the hashtag to do more radial cases, which I thought was fascinating. Moving on to advocacy, there are a lot of wonderful campaigns that we can join on in Twitter. The hashtag South Asian CVD, which brought a spotlight to a population which is at increased risk for cardiovascular diseases. In February, there was the hashtag Go Red for Women, raising awareness for cardiovascular disease in women. hashtag Face of Cardiology, which emphasizes diversity in cardiology. And then my favorite is hashtag Drop and Give Me 20, which I won't ask anyone to do now, but it's by Dr. Quinn Capers, and basically 20 push-ups a day. Even that can lead to meaningful improvement in exercise. Special mention for the hashtag Women in Cardiology. In 2019, in the United States, we have 12 states with less than 12 female cardiologists, as pointed out by Dr. Bob Harrington. At the forefront of this movement is Dr. Martha Gulati, and she gave a fantastic platform at ACC about hashtag ACC Women in Cardiology. And in fact, when she came here, she was very impressed by our female faculty and fellows, and kudos to our program. In terms of cardiovascular promotion, healthcare providers and hospitals are increasingly leveraging social media platforms to promote content on an individual, departmental, and an institutional level. Whether it's me talking about how great a job Fahim did at ACC, whether it's this hard to prove, no one knows who this is, but he likes to promote grand rounds, and then Dr. Zahbi obviously promoting the new Fellows Boot Camp this year on August 9th to 11th. Houston Methodist has actually done really well in terms of social media. They have a separate Twitter account for the hospital, a separate one for DICET, for the cardiovascular department, and in fact, one specifically for our fellowship. We cannot talk about social media without talking about pitfalls and precautions. So there are some best practices and basic social media rules, and the number one thing, if you take anything away from this, is never, ever, ever violate HIPAA. Know your institution's social media policy, always be professional, strive for accuracy, assume beneficence, and strive for accuracy is so important that it's in there twice. Some cautions and suggestions: set a time limit, don't be on Twitter all day. Identify a focus, always be civil. And in fact, from the debate between Dr. Gulati and Dr. Kern, the takeaway for me was this quote by Dr. Gibson, who said, "Tweet onto others as you would like to be tweeted upon." This is from our employee handbook. Essentially, we must, when using social media, always be in accordance with the Houston Methodist values and policies, and employees may not present personal opinions that in any way imply endorsements by Houston Methodist. In fact, now many of us see things like tweets are my own and don't reflect the opinions of my employer, and tweets are not equal to endorsements. I think it's a good idea to put that on your bio. So now that we know all that, how do we start? So choose your platform, create your account, and upload a professional photo, kind of like Dr. Jeroudi here. Briefly describe yourself, use hashtags if possible. So this is a renowned cardiovascular surgeon who says, I'm the chief section of cardiac surgery, director of minimally invasive cardiac surgery, and a jazz lover. I'm not going to say who that is, but it's Dr. Ramchandani. Follow key opinion leaders and societies. I personally really like Dr. Ziad Ali from Columbia, or the TCT conference. Always listen to your gut. You can be a passive reader or listener. 40% of people who use Twitter actually don't actively tweet. That's totally fine. Get involved in meetings where social media is accepted. In fact, most of the meetings now, social media is accepted. Post when comfortable, but always ask permission when in doubt. A few tips to increase your visibility. One way is to ask Twitter people to retweet. One is to keep it short, about 100 characters. And another way is to attach an image or a graph, something that will engage users. My personal journey through social media is that I was recognized by the ACC for being in the Members of Credentialing and Services Committee. A bigger honor was to be recognized by Dr. Zahbi, and then at ACC presenting science along with our mentors and program leadership. So this is our faculty on Twitter. Start following them. This is our fellows on Twitter. Start following them, and also follow our cardiac fellowship. In conclusion, I read this fantastic quote which says, "I use Twitter to keep up with the areas of science and medicine that I'm interested in. It is the first thing I look at in the morning to see what the people and the sites I follow have dug up and what they're thinking about. I read a lot and share everything. If we all did that, we'd all get smarter, faster." This was obviously a quote by Donald Trump. I'm kidding. This is by Dr. Eric Topol. who's obviously one of the most well-renowned cardiologists there. I'm so happy to be part of the Face of Cardiology in our fellowship. It celebrates diversity. This is the other face of cardiology with some sunglasses and some weird, peculiar expressions. Thank you so much, everyone.
Great, Wahaj. That was great. Very entertaining. I like that. We have time for some questions. Do we have any? Uh-oh, Dr. Kleiman.
Oh, man.
I didn't see his Twitter sign-up up there, but maybe it's coming.
Want to hide.
Yeah, so you actually didn't see my Twitter sign up because I'm still not quite clear how to use it. But, so this was great. And you very clearly made the point that social media are here to stay. It's a great way to find out what's happening. But let me ask you this. You started to talk about the downside. And the obvious thing is that there are things that are socially inappropriate or unethical that obviously we should stay away for. When are other times we should not rely on Twitter? So when, other than things that are abusive, when should we put the cell phone away?
Right, that's a great question. I think, so first thing is obviously to your point, I've heard where you should tweet everything as if it will be read in a court of law. So that's one thing that we should
yeah, but I'm not asking about
cognizant,
stuff like
yes.
that. I'm asking, are there points where, remember, information about the government that comes from the government is called propaganda.
Right.
When do we see that in medicine? How do we recognize it?
So I think
we follow
following-
KOLs. When should we say enough's enough?
Right. I think following impartial, or as impartial as they can be, societies and journals is a start to begin with, and then people that you know in terms of experts, I think that's a really good place to start following people on Twitter. I would not personally engage in debates about certain, even if it's trials that you feel very strongly about. Try to maintain civility, but I guess the point I'm trying to make is that we should always try to follow people who we trust are unbiased and leaders in the field. Yes, Dr. Ramsey. Well, they're waiting for you to make a Twitter account.
Yeah, Steve, first of all, I'd like to congratulate Omar and Wahaj for two splendid presentations. I mean, they really were tightly focused, really on point, and really, I think, serves as an example to many other speakers who have stood at the same podium, and I don't think delivered talks that are as well put together as this. So they really deserve a big round of applause for that. Let's go ahead and do that right now. So on the subject of social media, I'd like to pick up on what Dr. Kleiman was saying, and I think if I could summarize it in 2 words, I think he was bringing up the danger of fake news, if you like, and we know that this is a real phenomenon because even though all of the advice that you have given is sound and is ethical and it's proper, it's not hard to imagine that most people, and I can say this without any sort of evidence, but most people will not follow all of the advice that you gave, because implicit biases are very difficult to eradicate, and this will absolutely come out. Unlike a journal, which is peer-reviewed and which is filtered and which provides you information that is, I think, on a different level. And I think there's a real danger over there because even key opinion leaders, as Dr. Kleiman pointed out, I perhaps go further and say especially key opinion leaders, have strong biases towards one thing or another. There may be a handful that don't. Mm-hmm. And they use that platform unwittingly to propagate these views. So this is a real danger. Right. Another danger is a psychological one, and that's attention deficit disorder. And I think there's a real danger because you're looking at bite-sized pieces of information when in fact on any one subject that you care to mention, the truth is much larger and much more nuanced. which is impossible to convey in how many characters is it?
280 now. They aim to increase that.
And lastly, lastly, I would like to say that the phrase "CT is king" came from me.
Yes. Let that be known. Thank you.
So at the risk of offending my other imaging colleagues.
So, Wahaj, great job. So, my question for you is, your social media account is you, and it represents you as a cardiologist, but also you outside of cardiology, perhaps, if you choose to do that. So, I know there's a lot of people that discourage you from having tweets that are outside of your profession, and some disagree with that, and people are passionate about many things in life, including politics and other things. Yeah. And so, wanted to get your 2 cents on whether your tweets should be, in your opinion, focused on career and cardiology, or whether they should be broader.
So that's a great question. There have been talks of whether a person should be a whole person on Twitter or should they just be their career. I would advise all the fellows and all the early attendings, forget about the personal stuff. Just focus on the educational part of it, at least in your earlier years. If you're well known enough, maybe Dr. Zogby can tweet about his pet, but not nobody else. I think, I would not suggest that. Dr. Kasi.
That's what Facebook is for.
Yeah.
I just have one comment. I think one thing to be cognizant of is who is following you, because on Twitter, you can follow anybody you want to follow. Right. And a lot of my patients follow me. So that's an important thing to remember, that whenever you're tweeting about something, or let's say, for instance, venting, people use that. Mm-hmm. Also, that is something to be cognizant of.
Yeah, absolutely.
Listen, a good round starts on time, a great round ends on time. In the spirit of that and keeping this a great round, we're going to stop. So thank you both.